bringing you greetings from Varanasi and a very good evening to all my mentors, seniors, colleagues, and dear friends. My special thanks to Mrs. Stya Paul Awards, Aditya, Nishant, and the whole Walter Bushnell, Foundation, Health Foundation, for bringing us all together and giving us a fantastic hospitality. Thank you so much once again. Coming to my topic of comprehensive management of PPH, the worldwide prevalence of PPH is around 6 to 11%, and 52% of the maternal deaths are attributed to the three preventable causes, and that's hemorrhage, sepsis, and hypertensive disorders. WHO suggests that over 20% of the maternal deaths are due to PPH. And if we look into India, PPH accounts for 35% of the maternal deaths. So every 4 out of 10 maternal deaths in India are due to PPH. WHO defines PPH as greater than or equal to 500 ml of blood loss within 24 hours of birth. And the ACOG defines PPH as a blood loss greater than or equal to 1000 ml or blood loss accompanied by the signs and symptoms of hypovolemia. A small blood loss that makes a woman hemodynamically unstable could also be termed as PPH. The major cause of morbidity and mortality in the first 24 hours is called as the primary PPH, and if it occurs after 24 hours up to 12 weeks of pregnancy, it's a secondary PPH. If we look into the 4 important T's as the causes of PPH, they stand as the tone, the trauma, tissue, and thrombin. But looking into the atonic PPH is responsible for 70% of the causes of PPH. It takes a major toll. And the tone may be disturbed due to uterine overdistension, some muscle fatigue, infections, distortion, and relaxing drugs that we are going to use. Of course, for the tissue, we have retained placenta incomplete or maybe embedding placental areas. And of course, for the trauma, we have the cervical vaginal perineal tears, extension of tears, rupture, inversion, and of course, the coagulopathies need to be taken. We need to little scratch our heads to always pick up the high-risk factors like a prolonged labor, a grand multipara, augmented precipitated labor, a patient with a history of PPH, overdistended uterus, and operative delivery and chorioamnionitis. But at the state of admission, still we could categorize our patients something into a low risk, a medium, or a high risk. If she had an induction of labor, she's got multiple gestations, she's more than 4 previous vaginal birth, a prior, having large uterine fibroids with history of PPH, and so on. And we could grade them into high risk with placenta previa, coagulopathies, and so on. But if she stands to have 2 medium risk factors, she stands as a high risk. The blood loss could be estimated now by the visual estimates, or now we have the good collecting devices, and Fox has also brought about a collecting device for measuring the amount of blood loss and also with the shock index. So more than 500 would be an abnormal condition. If it's more than 1000, it's a severe PPH, and more than 2000 is going to be a massive hemorrhage. Therefore, World Health Organization recommends active management of the 3rd stage of labor for preventing PPH. Now, the use of uterotonics for the prevention of PPH during the 3rd stage of labor is recommended by WHO for all births, and oxytocin is recommended as a uterotonic drug for preventing. You do a controlled contraction where you have a trained birth attendant, but yes, in the cesarean, you could do a controlled contraction. The sustained uterine massage is not recommended as an intervention to prevent PPH in those who have received a prophylactic oxytocin. But what is necessary is a postpartum abdominal uterine dose assessment for early identification of uterine tony, which is recommended. It's more likely that the PPH would occur more in a cesarean, 6.7, as compared to the vaginal deliveries, which is 2.4%. So therefore, the international consensus on the use of uterotonic agents during cesarean emphasizes that oxytocin or carbetocin should be recommended during routine recommendations for all cesareans too. So coming to the uterotonic drugs, we have the posterior pituitary hormones and analogs, which stand as oxytocin and carbetocin. And we have the agot alkaloids as agometrin and methylagometrin. And of course, the prostaglandins, the PEG2, misoprostol, and the carboprost. But the posterior pituitary hormones, oxytocin and carbetocin, stand as the first-line agents. Oxytocin is short-acting, and it causes the receptor desensitization. The half-life is just 4 to 10 minutes. The duration is 15 to 20 minutes. To acquire a sustained uterotonic activity, you need to give it continuously. But when you move continuously and you give it in larger doses, there could be adverse effects like hypertension, nausea, vomiting, dysrhythmia, or pulmonary edema or a water retention. Oxytocin is used for inducing and augmenting labor. It may desensitize the oxytocin receptors, thereby it's going to impair the oxytocin's post-delivery effects on the uterine contractility. But an oxytocin receptor inhibition starts at 4.2 hours and is going to completely inhibit in 6 hours, whereas carbetocin is devoid of all this. So different international bodies recommended different doses of oxytocin, and there was no consistency in the dose of regime. Therefore, errors could occur, and the Institute for Safe Medication Practices added IV oxytocin to the list of high alert medications, meaning minor errors could cause a significant harm to the patient. Oxytocin is sensitive to heat exposure. It needs to be transported and stored at 2 to 8 degrees centigrade continuously. So the need of an hour was a long-acting, no variation in dose regimes, ease of one-time administration, a superior efficacy or a similar efficacy to oxytocin. It should be devoid of receptor desensitization and superior side effects profile over oxytocin. And the drug which came up was carbetocin. It's 100 ml in 1 micrograms in 1 ml. Now, this carbetocin is a synthetic analog of human oxytocin. It's got certain structural modifications as shown here are like the amino group in the cysteine has been replaced by a hydrogen atom. The bisulfide bond has been changed to a thioether bond, and the hydroxyl group of tyrosine has been substituted by a methyl ether. But all this did wonders that it became resistant to aminopeptidase. So once it became resistant, it was not degraded. And this led to a structural modification, and that was the increased half-life of carbetocin, prolonging its pharmacological effects. It acts by binding to the myometal oxytocin receptors. And once it binds, it's going to cause rhythmic contractions, and that's going to increase the uterine tone and take care of uterine atony. The onset of action starts just in 2 minutes, and look at the half-life. It's 40 minutes at almost 10 times longer than oxytocin. And therefore, 1 dose of carbetocin is equal to 16 hours of oxytocin infusion. The renal clearance of this unchanged form is low, less than 1% of the injected dose excreted, unchanged by the kidney. So, it's recommended in all the vaginal as well as cesarean deliveries. Oxytocin still stands as a choice. But there are certain contraindications. Do not give it during pregnancy and the labor before the delivery of the infant. It should not be used for induction of labor. And hypersensitivity to carbetocin or oxytocin, hepatic or renal diseases, serious cardiac disorders, or epilepsy, and to be used in caution with hypertensive patients. Now, small amounts of carbetocin have been shown to pass from the plasma into the breast milk of the nursing mothers. But what happens is that this is being degraded by the enzymes in the gut. So it's very safe, and she doesn't need to stop the breastfeeding. Pediatric less than 18 and more than 65, it's not recommended for use. Looking at the drug interactions, due to similarity with oxytocin, the occurrence of the interactions known to be associated with oxytocin cannot be excluded. Severe hypertension reported when oxytocin was given 3 to 4 hours following the prophylactic administration of a vasoconstrictor. Enhanced blood pressure, enhancing the effect of ergot alkaloids like methyl agometrin. Like oxytocin, carbetocin effects can be potentiated with prostaglandins. Arrhythmia has also been reported for oxytocin during its concomitant rate. Europe temperature always below 30. suitable for those below 30-degree products. But India has a temperature which is above 30 degrees, so it's not suitable for those below 30-degree products. So we needed a new formulation of carbetocin, and that was which is stable at the room temperature. Looking at the stability of carbetocin, below 30 degrees is stable for 3 years, at 40 degrees centigrade for 6 months, at 50 degrees for 3 months, and 60 degrees centigrade for 1 month. And that's the stability of this molecule. So there was a reduced need for uterotonic agents, a longer half-life, no cold storage, and a good tolerability. Oxytocin displaces the high structural similarity to vasopressin, and this hormone is involved in the regulation of water reabsorption. So water retention in the body can lead to disturbed sodium levels, and oxytocin has got antidiuretic effects. An IV infusion could cause water intoxication and an acute form of hyponatremia. But carbetocin is 24-fold less potent than oxytocin at the vasopressin receptor, and therefore a reduced risk of hyponatremia. So it stands superior to oxytocin, to the ergot alkaloids, and also to the prostaglandin analogs. So therefore WHO Essential Medicines list carbetocin has been included to be used as a preventive medicine for PPH. Looking into the IOG guidelines, there is no statistically significant differences between carbetocin and oxytocin in terms of risk of PPH. SOGC guideline recommends carbetocin should be used for prevention of PPH in an elective cesarean section. Give it as an IV bolus, but slow in 1 minute. WHO has included carbetocin as an effective uterotonic in 2018 guidelines, and carbiprost is not recommended by WHO. FIGO and ICM strongly recommend the use of uterotonics during the active management of 3rd stage of labor to prevent PPH during the vaginal birth or a cesarean section. Also, the international consensus statement on the use of uterotonic agents during cesarean preferred carbetocin as the first line rather than oxytocin, and this eliminates the requirement for an infusion after the initial dose. FOXI strongly recommends carbetocin to be used in the vaginal as well as the cesarean deliveries. Carbetocin has been used and studied worldwide. There are a lot of clinical studies on carbetocin. The CHAMPION trial, which was done and carried out by WHO for carbetocin versus oxytocin across 23 centers in 10 countries, including India. It was a non-inferiority double-blind randomized trial with 30,000 women, and this proved that carbetocin is non-inferior to oxytocin with the ease of a single dose administration. Carbetocin versus oxytocin in active management of 3rd stage of labor following vaginal delivery said a single dose is more effective for maintaining adequate uterine tone. And when this was used and compared in cesarean section, both the groups had comparable blood loss and the operative time was also reduced. Prevention of PPH from cesarean, comparing carbetocin with oxytocin versus misoprostol, when all three were compared, carbetocin was superior and safety-wise better than oxytocin and misoprostol. Comparing carbetocin with oxytocin plus methyl agometrine, there was a reasonable effective alternative. It stood as an alternative to centometrin in prevention of PPH for cesarean delivery. Carbetocin versus oxytocin was compared in patients of PPH in severe preeclampsia. And when the study they said carbetocin is an appropriate alternative to oxytocin for preventing PPH in women with severe preeclampsia, considering that it appears not to have a major hemodynamic effect in women with severe preeclampsia and that it uses a low volume per dose than oxytocin. It should be considered a valid option in the management of 3rd stage of labor in women with hypertensive disorders of pregnancy. This was also tried and used into the twin pregnancy that underwent cesarean section. And once they were used, the conclusion was that in the twin pregnancies that underwent cesarean section, 100 micrograms of carbetocin to regular Uterotonics decreased the total blood loss and the risk of undiagnosed PPH, and it also reduced the need for much more fluid supplementation. Also, there was a comparison between carbetocin and oxytocin for preventing PPH in cesarean deliveries for placenta previa and accreta. And compared to oxytocin infusion, carbetocin could reduce the requirement of additional uterotonics in procedures like cesarean deliveries, which were done for placenta previa major. Non-clinical data revealed no specific hazards for humans based on the conventional studies of safety, pharmacology, repeated dose toxicology, genotoxicology, and local tolerance. No other toxic effects were observed, and carcinogenetic studies have not been performed due to the single-dose nature of the indication. Therefore, studies in the use of carbetocin following cesarean also demonstrated a safety and side effects profile which was just similar to oxytocin. FIGO proposes a bundle approach in the management of PPH with uterotonics as the fundamental. The recommendation stands as readiness, recognition, response, and reporting. The first step in readiness is the use of a uterotonic for the third stage of labor for all the births, which is an important component. If a woman experiences PPH, implementation of a first response bundle is recommended with uterotonics along with the crystalloids, uterine massage, and tranexamic acid. WHO recommends administering 1 gram of tranexamic acid at the rate of 1 milliliter per minute, which is to be now given as 1 gram in 10 minutes intravenously soon after birth. And if the patient still continues to bleed, you can give another shot 30 minutes later. The drug is going to be most effective if you give it in the first 3 hours of the onset of bleeding. If she stands to be a refractory PPH, the bundle continues uterotonics, tranexamic acid, but may be accompanied now by compression approaches and uterine tamponade. And further, the non-pneumatic anti-shock garment is recommended, and uterine artery embolization could be the conservative measures. But if still it doesn't stop, the surgical interventions, use of compression sutures, uterine and hypogastric artery ligation, and hysterectomy. So FIGO considers bundle care approach can move patients' outcomes and improve them when you adhere to all the components is high. But we need to stay alert and put all the guidelines as memories, because women with a prior PPH have as much as a 15% risk of recurrence in a subsequent pregnancy. The greatest danger in the times of turbulence is not the turbulence, but it's an untimely action. So making the next right decision should happen right now. And this is how we're going to paint a beautiful canvas of this woman, because she says, I'm strong, I'm beautiful, and I'm enough. So thank you so much for this patient here.
Thank you, Dr. Ritu Khanna, for beautifully bringing out how to handle PPH, how to prevent and how to handle. We must remember that India has come a long, long way from the maternal mortality of over 500 during when we were studying. 500 per hour, or jumbo jet crashing every hour, and it was not making news. So there was no political will, there were no new drugs, nothing was there. And then finally, the government woke up, there were government schemes, institutionalizing deliveries, and improvement in the drugs. We were only given, we only knew about methergin, and then the syntocinon, and then of course we had prostaglandins and now carbetocin. Just remember, carbetocin is for prevention and not for treatment. For treatment, you still have to use the other oxytocins. So that the general public should take home that it is not a treatment drug, it is a prevention drug. And it prevents very nicely. That is what is needed. And FIGO, Foxy, everything. Then to bring down the maternal mortality less than 100 was to control infection in PPH. And here is where Foxy has played a major role in training the private nursing homes and small hospitals in 2-tier city by the Manyata program. Rishikesh is here. That Manyata program has played a major role in bringing down the maternal mortality. And those of you who are here and who have small nursing homes, please get Manyata trained. It will give you NABH. We have Manyata Lakshya now. The government is training their hospitals. Government is strengthening their government sector. The private practitioners are the one who are going to take the hit. And that is where Foxy stands with you as a Foxy past president and a center of excellence for Manyata. I urge all private practitioners to get trained in emergency obstetric care, PPH management, preeclampsia management by getting a Manyata certified hospital. We train all your staff, we train all your doctors for a very small fee, and you get certified every 2 years. So that is one of, and of course, the newer drug carbetocin is what we need to do for prevention. So thank you for being here. Thank you, Dr. Ritu, for beautifully bringing out how this drug acts.
Thank you. Thank you, Dr. Ritu, for beautifully highlighting all the aspects of carbetocin, spalcine, and it really has replaced oxytocin in many hospitals. But as Dr. Narendra said, I mean, carbetocin is for prevention, and it does it so beautifully because of its prolonged action. And usually, if you can prevent PPH, so treatment will be required in very less number of cases. But if then it happens, then you have to treat it as you showed in your algorithm. Another advantage of actually carbetocin is that even in patients with cardiac conditions and preeclampsia, etc., so it is a slow action. So if you use oxytocin, there is sudden actually hypotension and sudden hemodynamic instability. Patient can throw a fit and all. So carbetocin is very useful for them by slow action and prolonged action. So it's another advantage of carbetocin for them. And it also can be used easily for multiple gestation, polyhydramnios and all, because it has a beautiful preventive action. So these are extra advantage. But of course, treatment ultimately remains oxytocin, ergometrin, prostaglandin, all others as you showed in your decision. So thank you very much for that.
Thank you, sir.
It was a very nice presentation by Dr. Ritu. And so far as PPH is concerned, mostly it is because of in most of the cases, it is because of the bad obstetrics. So we should be very careful in apprehending. And first stage and second stage of labor is very important if you really want to prevent PPH. And so up till now, there has been only non-inferiority trials. But as we have seen with Dr. Ritu's paper, that there are many superiority trials in certain conditions. It has proven to be better than oxytocin, like preeclampsia, and as Dr. Sharma added, in cases of heart disease. So that is very important and takeaway message for most of us. And it has got a very long life. So that is also very important. We will not let the patient have PPH, so there will be no need for treatment of PPH. And if still PPH occurs, in most of the cases, it is not because of atonic uterus, but it is because of some other reason that it happens. So this is a very good drug, especially for our country where the climate is so bad. In most of the cases, the temperature is beyond 40 degrees centigrade. So it has got the maximum benefit of being stable at high temperature. Just now we have seen how it is stable even beyond 60 degree. So that was the first advantage that we came to know. But gradually we are coming to know better and better. It is proving to be a better and better molecule as compared to oxytocin. But it could not replace oxytocin because that has got a great role in induction and continuation, if there is continuation of PPH and continuation of therapy. So it was a very good presentation, and you have highlighted all the points in favor of carbetocin, and most of us are using carbetocin for the prevention of postpartum.
And preeclampsia, actually, ma'am, it's going to push a less volume rather than the oxytocin and all. So it's always preferred in the severe preeclampsia.
At the offset, I would like to congratulate Walter Bushnell, because I think PPH is one of the very pertinent topics which they have chosen, and I'm very, very happy that it has been chosen. And congratulations, Dr. Ritu, because we all know that maternal mortality is 14 times higher in developing countries, and in 25% cases, it is a cause of maternal mortality. And we all know that there are 7 states in the country which have a very, very high mortality because of the PPH. And very, very important thing, that in 19% of the women, there is no high risk factor. So that is what is very, very important point that in 90% of the women, there is no risk factor. So for every patient, every woman who is going into the labor, we have to be mentally, physically, and team-wise ready. It is very, very important in every aspect, and we have to do active management of third stage. But there is one more stage which has been added recently, that is the fourth stage of labor, where the PPH occurs after the delivery, where we miss it in first 24 hours. That has also to be kept in mind. And another very important thing is that we have got 3 Ds in every PPH, where there is a delay in the recognizing the PPH, delay in transfer, and then again delay in getting the proper treatment. And we need to anticipate, identify them at the right time. And very pertinently, Dr. Narendra Malhotra pointed out, there is, as per the data, there are only 42% of personnel who are trained for this. And there is a huge need to train rest of the people. And as Sir has already mentioned, that Manyata is a very, very good program, and Manyata champions. There are 20 standards, and those standards have really helped lots and lots of people. And it is high time that each and every institute, from a smallest of nursing home to the largest of center, we are better than even NABH when we talk of Manyata. So I request each and every one of you who are sitting here, because there are so many thousands of centers, but very few of them are recognized with Manyata. You must take up Manyata, because it not only trains doctor, it trains your staff who is there in your hospital looking after your patient throughout the labor. So before ending all this, I would like to just add one thing, that whenever we talk of PPH, it is prevention, 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 and prevention. So please work towards prevention. And as already told by everyone, I would like to reiterate that when we talk of prevention, carbutocin is a very good drug with the stability, with fluid, and everything else. It is high time we shift to this drug and look into it, because it has got many, many more benefits. Thank you very much.
So that was a very excellent deliberation. So quite a lot of things have been spoken about the medical aspect of PPH. So I think we'll also like to know a little bit about the surgical aspect. So when it comes to surgical aspect, I think the key principle is that 2 things. One is the ligation and another is compression. So we need to make sure that we take care when it is not responding to with any of our active management with these medical support, then ultimately we need to resort to surgery. So every obstetrician have to be well trained and tuned to manage the acute crisis surgically as well. So it is a lot more easier when we are doing a cesarean section, because we are there in the field. But when it comes to a normal delivery and if we are encountering a atonic PPH, then again it is a task, because you have to gather your team to make sure that you are able to perform the surgical procedure and control the acute episode. So when it comes to ligation, the key factor is that we need to take care of the 3 major bleeders. The uterine vascularity has to be taken care. So we have to ligate the uterine artery, then of course the ovarian artery, and also the descending branch, so which supplies the lower segment of the uterus. So while doing these things, various compression procedures have also been designed. So by different authors. So the ultimate is that, as I mentioned, it is just we have to cut off the blood supply a little bit and also put pressure on the uterus, compression. So that is the reason bimanual compression we are doing. So the same thing now, various technical procedures, like you have the B-Lynch procedure, the Heymans, and all those, the Cho sutures. So all this is ultimately compressing the uterus. So they have also reported, like where, like they put the assistant and the surgeon literally compress the uterus so hard in such a manner that the uterus, the supply to the uterus is also cut off for some time, by which we are able to control the bleeding issues. So I think along with the medical management, of course, carbitocin is a real wonder drug, and we have known how prevention is better than cure. So the active management in the third stage is very vital. Along with that, also starting carbitocin for every woman who is delivering is also very important, so that we can always prevent rather than struggling for cure. So I would like to highlight on the surgical aspect as well. Thank you so much for giving me this wonderful opportunity.
And also, I think every hospital, every this thing should have PPH drills in their hospital, and they should train the youngsters, as Manyata is one of them. But otherwise, also, I think everyone who are dealing with obstetrics, so, and because PPH can come like a bolt from blue without unexpected. So, I mean, carbitocin will prevent in significant number of cases, but still it can happen. So, PPH drills like we routinely use at AIMS, so that is very useful thing. PPH drill, shoulder dystocia drill, so that when suddenly it happens, people are tuned to it. Thank you.
May I? Congratulations, Dr. Ritu. Excellent presentation. I fully agree with all the comments. I want to add a few words about the importance of prevention in diagnosing adenomyosis. This is an important point, and the fusion between obstetricians and gynecologists is fundamental. Because before pregnancy, you have the chance to make a right diagnosis of one of the most important factors in determining PPH after the pregnancy. So informing the patient and informing the colleague, the doctor that we follows the patient is fundamental. Believe me, it's not so rare.
Right.
Thank you.
Thank you. Thank you.
So, Rupi could tell about Italy. We have esteemed guest from Kenya, Nairobi. Sir, do you want to say anything about PPH is common in Kenya also? You want to say something? Yeah, thank you.
Thank you. We are happy to have been invited to attend this session. I'm with two of my colleagues here. Before I make a comment, I need to say one, the studies which was done for heat-stable carbitocin was done in our hospital as one of the centers in Africa, and it's in the publication which I'm sure all of us have read.
Yes.
PPH is a story we have had over the years. It's one of our commonest disasters. And we always say, whenever a patient has got a PPH, it means something was missed before the PPH occurred. So good history taking, anticipation of what was happening, and especially for a patient whom you have been seeing or who comes for delivery, take your good history, anticipate and prepare before. We all know, we are all obstetricians here. When you prepare for a PPH, that story will be solved. If you're not ready, things will not work. Multidisciplinary approach, you must be competent in handling this patient. You must be competent in a surgical intervention, as Dr. Raj has put forward. Anybody managing a PPH and you do not have the surgical skills, that patient will be able to go. And surgical skills, it starts from how are you able to handle that uterus so that you'll be able to know what you do. Don't waste time doing uterine compression when you know it is not going to achieve anything. The period you take trying to fight and doing the uterine compression, how much blood will you have lost? Any 100 mils of blood lost in a woman who is having PPH is pushing that patient closer to her grave. So you must have that you must have that reasoning element of when do I intervene and what do I do? If you don't know what you are doing, please call for help. And PPH is a multidisciplinary approach, which if you don't do that, you are gone. Lastly, for PPH, please always have things to be of assistance. You must have a functioning blood center. We say where we come from, PPH is a contributor to 40% of maternal deaths. So we are worried about patients with PPH. Interestingly, because of the effect of PPH you have had and a lot of studies you have done on PPH, using the carbetocin, stable carbetocin, the emotive study, the champion trial, which you have been involved in, most of our people now know how to manage medically PPH. The issue of surgical is where the issue comes in, because most of them have got placenta crater spectrum, which we must all be aware of. We are having a lot of it because our C-section rates, I don't know what it is now in India. In our teaching hospital, we are having a section rate of about 52%. And that has increased our element of placenta crater spectrum, which I'm the lead in trying to make sure that we teach our students how to handle placenta crater spectrum. So in a nutshell, I agree with the panelists. PPH, what you see in India is exactly what we see back at home, and it is a disaster.
Thank you, sir. Thank you, sir. Thank you.
Thank you, sir. What you have really pointed out, very important thing, the golden hour.
Yeah.
So golden hour is one of the very important thing which we must keep in mind, that we have to manage the patient in the golden hour, diagnose it early, refer it early, and manage it early with medical/surgical, whichever way. Thank you, sir. Thank you very much.
I think we can close the session. Yes, thank you.
With that, I thank the distinguished panel for a very insightful and engaging session on comprehensive PPH management.